All right. Hello, everybody. We're going to go ahead and get started. My name is Amalia Weber. I am the program specialist here at Rochester Hills Public Library, and I'd like to welcome you to this evening's program, Health Talk, Regain Bladder and Bowel Control. Before we get started, I'd like to take care of a few housekeeping details. Firstly, tonight's program will be recorded and available to view about 1 week from tonight on our YouTube page and on the RHPL website shortly after. We ask that audience members please silence or turn off their cell phones before we begin in order to avoid any disturbances during the presentation. Our next program is Maximize Your Medicare, which will be an in-person event on Tuesday, January 31st at 7 p.m. You can sign up for that at calendar.rhpl.org. Additionally, I want everyone to know if anybody can't see or has trouble seeing the screens up here, please let me know and I can dim the lights to help a little bit. Just come and let me know. And now, without further ado, please welcome our presenter, Dr. Felix Lee.
Can everybody hear me okay? All right. So thank you all for coming, despite the cold and the snow. So my name's Dr. Lee. I'm one of the colorectal surgeons at staff at Troy Beaumont Hospital. I think the flyers had mentioned that I work out of Ascension, but that was a little typo. So I do my cases at Troy Beaumont Hospital, and the business card that you have will give you access to my clinic number. I have 3 different clinical locations, one in Rochester Hills, one in Utica, and one in Troy. So the reason I got together with our nice folks at Medtronic about this topic of fecal incontinence is because it's actually very, very common. And that's a little bit more about myself. And it's not only is it common, but patients often don't know that there are treatments that are pretty non-invasive. And that's what I'm here to talk about today. And this treatment has to do with placing a nerve stimulator that works for controlling both your bowels and your bladder. But just as a side note, I'm an expert in colon and rectal surgery, not necessarily bladder surgery. So that's the topic that I'll be focusing on today, which is fecal incontinence. Okay. So it depends on what kind of studies you look at and what numbers you look at, but it's pretty common. Up to 20% of patients will have some type of control issues with their bowels, whether that's to controlling your stool or to gas. And this is something that impacts a lot of Americans, and this is something that can really, really reduce your quality of life. I think it's important to define what's normal and what is not normal in terms of bowel function. So what I mean by incontinence is that you're not able to control your stool or gas, meaning you're having accidental leakage of either solid stool or liquid stool, or also to gas itself. And this is something that obviously has a big impact on your quality of life. And if this is something that's been going on for more than about a month, it's definitely something that you should talk to your physicians about. Okay. I've already kind of talked about this, but not only do patients know about all the different treatment options for fecal incontinence, but I realize that some of the family medicine doctors and primary care physicians, they don't really know that there are pretty non-invasive methods to treat your symptoms of incontinence. So what is fecal incontinence? There's different types, whether it's urge incontinence or passive incontinence. It really doesn't matter. It comes down to any type of accidental leakage of stool or gas that you find is distressful, that has been going on for more than a month. And if you've done any Googling or any kind of research on your own, you'll find that there's many different types of what we call questionnaires and scales to document the degree of your symptoms. But what it comes down to is, do you have leakage of stool or gas? Has it been going on for about a month? And is it affecting your life? Whether that means you're not able to carry out your social activities, go out with your friends, or having to depend on wearing, Depends or padding in your underwear to control that leakage. So there are multiple treatment options. And I'm going to just generally go with the least invasive method or conservative measures and kind of go about talking about what the typical treatment pathway would be. So the first thing that we would do is, of course, I would see you in clinic and get an assessment of what we think is causing your incontinence. There are multiple different things that are involved in your ability to control your bowel movements, and it doesn't just have to do with your muscle function. There are different things that we can do to assess your sensation, your muscle tone. We do a complete history to see what type of surgeries you've had in the past. What is your history of pregnancy? Was it vaginal birth, C-sections, and things like that? And what is your list of other medical conditions that might be impacting your ability to control your bowel movements? So in terms of conservative treatments, luckily, about half of the patients that have fecal incontinence will get better without surgery. I think that's something that a lot of people ask about. And this has to do with making changes in your diet. So for example, we know that there are certain food triggers like caffeine, rhubarb, that causes, and especially artificial sweeteners, that causes you to have diarrhea. And we know that one major component of fecal incontinence is you not being able to basically sense that you have stool. And it's just in general difficult to control liquid stool than it is to control formed, bulked up stools. So there are certain changes that we can make to your diet to hopefully resolve your symptoms without resorting to surgery, for example. We know that exercise in general is good. A moderate level of exercise, maybe 20 minutes at a time, getting your heart rate a little bit, about 3 times a week, that's good. And physical therapy here specifically refers to pelvic floor physical therapy. Just like you can have PT for shoulder pain, joint pain, or after a musculoskeletal injury, you can have the same thing for pelvic floor. Because we all have this cup of bone that we call the pelvic floor, and the inside of that cup is lined by muscle. And there are different types of muscles in that group that are responsible for controlling not only your bowel movements, but also your bladder control as well. And sometimes even if you have the muscle groups intact, the coordination might be off. Like they might not be firing off correctly. And one thing that we can do to treat that is through physical therapy. And there's a specific thing that we do called biofeedback, where we are basically retraining your pelvic floor muscles. And these are all things that we consider to be conservative and pretty non-invasive. There are also medications that we can try as well. But generally, what they do is they try to slow down your bowel movements without causing constipation. Examples include things like Imodium. But the first thing that we always do is adding more fiber to your guts. Okay, we all need if you're a man, you need about 30 grams of fiber. If you're a lady, you need about 35 grams of fiber. And fiber is a type of plant-based kind of carbohydrate that we all need in our guts to regulate our bowel movements. And this is the first place, if you were to see me in clinic, I would start with to kind of bulk up your stool and keep the bowel movement consistency in the middle without causing constipation or diarrhea. So these are examples of some of the kind of what I would consider to be, conservative treatments for incontinence. And like I said, about half of patients that come to my clinic often get better just from this. Okay. So what happens if you don't get better? And that's kind of why we're here today with Medtronic's. So the Medtronic InterStim system is something that was approved by the FDA actually more than a decade ago for controlling your bowel movements better. And this is something that has really, come a long way since it was kind of first started in 2010. And it's been shown to improve your quality of life, okay? So how does it do that? So what it is there are multiple phases of doing this. It comes down to stimulating a certain nerve in your spinal cord that is responsible for your bowel function. Now, we don't really know, why this works, but we know that it works. And our best guess is that, I mentioned that there's different causes, our best guess as to why this works, how this works, is that it improves your sensation. So for some reason, by stimulating this nerve with a constant kind of basically a shock without causing pain to the nerve, we're able to improve your sensation of your rectum so that it senses better when it's filled up with stool, so that you can evacuate when it's appropriate to do so. We think it has more to do with sensation rather than like motor control of the muscles per se, but that's what we think is going on. If you want like hard numbers, so typically we say about 90% of patients, 85 to 90% of patients will see an improvement or will see some success with this treatment. And we measure that by different means, but basically if you have more than about a 50% improvement in your symptoms, we say that's a success. And actually, about 40% of patients will have complete resolution of fecal incontinence, whether that's to stool or gas. And so if I'm kind of going through how it typically works is, let's say we've gone through the typical steps of doing the conservative measures and it didn't work, and we're agreeable to doing this thing. We would start with what's called a test phase, a PNE, for example, in the office, where we're able to place a lead into the spinal cord just under local anesthetic, which means we numb the skin with a needle. That's the worst part of the procedure. And then we're able to place the lead. And one of our reps, nice reps in the back, will be with me in clinic while I do this, because there are certain things that we look for to make sure that it is truly in the right place. Because as you can imagine, there's multiple nerves back there, And so Nancy, for example, will help me to make sure that we have it in the correct place. And then what's going to happen is you're going to go home for about a week, and then you're going to keep track of your symptoms. How many episodes of incontinence are you having? Has it gotten better? Has it gotten worse? And if there's about a 50% improvement in your symptoms, then we go ahead and implant basically the permanent lead in the operating room. So that's an outpatient procedure, meaning you come in and you go home on the same day. You'll be under sedation, which means you'll have someone that'll drive you to the hospital and back. But it's a relatively quick procedure. That's going to take probably an hour or so. And patients tolerate it pretty well. So, I've talked about the benefits, what are the risks of the operation. They're pretty minimal, but there are certainly risks, whether it's pain to the area, bleeding from the area, or infection to the area. The infections are typically not severe enough, but if they are severe enough, we may have to remove the device to get rid of the source of the infection, but they're pretty rare. The other thing that could happen is dislodgement or misplacement of the lead as you're moving around and stuff, in which case it may need to be replaced with another procedure. Okay? But patients, like I said, they go home and they're able to carry out their daily activities and kind of go from there. I've already mentioned this, about 89 to 90% of patients will see improvement in their quality of life, and we define success as more than about a 50% improvement in your symptoms. So, the biggest question is, are you a candidate or not? And that's a judgment call that we'll kind of make after I've had a chance to talk to you and make sure that there's nothing else going on. We want to make sure that you're up to date on your colonoscopies, make sure we're not missing the big picture here. But the best way to find out if this is the right choice and if it's something that you are more interested in is to basically have a discussion with me in clinic after we've completed your kind of complete history. Okay? This is, something that's been around since 2010. There are other products out there, but this is the one that I would favor just because it has the longest track record of, having worked, and we know exactly what to do. So I'm going to pause here for questions. Yes.
Is a patient with a uterine rectal prolapse supposed to have surgery for it?
So if you have, that's a good question. So rectal prolapse is a condition where a part of your rectum literally falls out of your body. It's a separate process from hemorrhoids, but anyways, if it's truly rectal prolapse, I would recommend fixing that anatomic defect before proceeding with this procedure, because rectal prolapse itself can cause fecal incontinence. And that, is another discussion that we can have, because that's a whole nother talk. There's different types of surgeries that we can do, either from the belly or from the bottom. There's different approaches, and each has its set of pros and cons and risk and benefit. But the short answer to your question is I would recommend fixing the prolapse before doing the stim placement. Mm-hmm. Yes?
Is Metamucil a good source of fiber?
Yeah, that's the one that I take. Yeah. So Metamucil, the buzzword that you're looking for in terms of your fiber supplements is psyllium husk. That is a plant-based fiber supplement that has basically no side effect. My recommendation is typically the powder formulation without the sugar, because fiber is something you take every single day as a supplement. And in doing so, you're actually going to prevent a lot of these issues like hemorrhoids and tears on the skin that you can have down there called a fissure. Basically, reasons to see me in clinic you can avoid by taking fiber. Okay?
Because I started the Metamucil about 11 days ago, and it's actually made a huge difference. I've been taking one a day. Is one a good amount to take?
So in general, you need about 30, as a lady, you need about 35 grams of fiber in your guts. What I generally recommend to my patients is try to get about 10 grams in supplemental fiber, and then the rest of your fiber will come from your food intake. Okay? You don't want to take too much fiber and not enough water, because that can actually bind you up a little bit. So a good rule of thumb is about 6 cups of water throughout the day. Not with the fiber itself, because it's going to be, because you'll probably notice that if you mix it into water and you let it sit, it's going to turn to jello.
I've been taking like the little tablets.
Yeah. So I would just read the nutrition label and see exactly how much fiber you're getting per tablet, for example, and then aim for about 5 to 10 grams in fiber. Yeah, that's a good place to start, and that's where I would start if you were to come to my clinic too. Mm-hmm. Yes, in the back. It's all the same. What's more important to me is that you're taking whatever it is that works for you. The hardest thing about fiber is taking it consistently. If you're taking it because you have diarrhea, or if you're taking it because you have constipation, you've kind of missed the boat. It's something that you take every day to prevent these issues from happening. What I've found is that if you're trying to get about 10 grams of supplemental fiber as a gummy or as a capsule, you'll notice you're going to be popping gummy bears like 8 to 10, 3 times a day. So what makes more sense to me is to just take the powder formulation, do a couple teaspoons, and just get it out of the way, Yeah, that's a good question. Anything else at this time? Yes? Flax seeds? It's just another form of fiber. I would consider that as just part of what you eat. But I've noticed that if you actually try to kind of, just like you have people that try to count calories, if you try to count the fiber, it really doesn't have that much fiber, which is why I recommend taking something in addition to that, whether it's Metamucil, Benefiber, Consul. There's a whole bunch of things out there, but the buzzword that you're looking for is psyllium husk. That's the plant-based product that I recommend.
Is it psyllium, S-I-L-I-U-M?
P-S-Y. I know. Psh, didn't see that coming, right? Yeah. P-S-Y-L-L-I-U-M. Yep. Mm-hmm. Yes.
Excuse me, a line.
Align. So that's a probiotic. That's a little bit different from fiber. So probiotics in general, what they are, they're basically, bacteria. Okay. We all have bacteria that sit in our guts. Some of them are good. Some of them are bad. What you're doing by taking these probiotics is you're making sure that the good guys outnumber the bad guys. And that's also something that you take every day. And what I generally tell my patients is if you've taken a course of antibiotics, after you finish the course, it's a good idea to basically replenish your guts with good bacteria, like Align, for example. We're finding out, more and more these days about the importance of having the right balance of bacteria in your guts, and taking something like Align, or frankly any other products, under the probiotics category, I would just recommend getting the cheapest bottle. You're making sure that the good kind of bacteria outnumber the bad, and that's another thing that's helpful in regulating your bowel movements. Making sure that it's not too wet like diarrhea, and also not too hard and firm like constipation. Yeah. Anything else? So that's all the talk that I had prepared for you guys. It was just kind of a brief introduction to fecal incontinence, and what we can do in terms of managing your symptoms, starting with what I would consider to be medical or conservative measures, and kind of working our way up to something like this, where we place a stimulator in your back. And you have a pocket, I forgot to mention this, but you do have this, a battery that hooks up to the generator that hooks up to the lead that goes in your back, and that's going to sit just above your hip bone in the back here. And for that, because that is rather painful to do in the clinic, that's the reason we do that operation in the operating room. But yeah, so there are other options, surgical options, but this is becoming more and more of kind of the first line treatment for fecal incontinence. Yes, there are operations that we do. There's an example of a sphincteroplasty, for example, is an operation that we still do actually for patients that, for example, have fecal incontinence secondary to a muscle defect, where they have injury to the muscle, the sphincter muscle. But we're finding out more and more that whether or not you have this injury to a muscle called the sphincter muscle, this is a device that works, the Medtronic stimulator device. Mm-hmm. Oh, yeah.
My mom tends to handle hers with Imodium and then Colace, and back and forth. Any suggestions on getting out of that?
Yeah, so Imodium is something that'll basically, it's a treatment for diarrhea, but if you take it, it basically causes constipation. And Colace is an example of a stool softener that you use in people that have constipation to basically cause diarrhea. So you're taking two medications that cause one extreme or the other. So what you want to do is regulate all that by just adding more fiber to your guts. That's the first place you should start with. And then it's okay to take, for example, if you're still feeling backed up from constipation, or if you feel like you're having watery stools from diarrhea, then it's okay to kind of titrate your stools by taking those over-the-counter medications. But that's not where you should start, because if you do that, you're just going to be bouncing from constipation to diarrhea, and then from diarrhea to constipation. So fiber. That is, yes, fiber is good for you.
This is it causes the diarrhea, so you say then take the Imodium, but don't stop the fiber.
Correct, yeah.
Is there a special time to take this fiber at night or not?
It really doesn't matter. So if you ask different people, they'll tell you different things. But what's more important than when you take it is that you take it at the same time every single day. Okay. Generally, I think it's a good idea to take it in the morning. when you are about to get up and start your day. Because then throughout the day, you can add water to your guts, to your fiber. But if you take if you take a lot of fiber at night, you're just gonna go to bed without having to drink water throughout the night. And some patients might actually get a little bit bound up with that. So in general, again, you'll hear different things from different people, but I think it makes sense to take it in the morning. Yeah. Yeah, no problem. Yeah.
The canister of Medicare to take it 2 hours after a meal or 2 hours before. Is that important or not?
Not to me. Yeah. Whatever. So again, if you feel like you're more consistent, you're gonna be more consistent doing it after or before. That's fine by me. There are certain medications, for example, a certain type of blood thinning medication that you don't want to take with fiber, something like Coumadin, for example. So you want to kind of separate when you take your blood thinners versus when you take your fiber. That's in general a good idea. But whether you take it before or after a meal, it really doesn't matter.
How close to? Thank you.
Mm-hmm. Yes.
Besides the fecal incontinence, are you going to touch on the bladder, the urine incontinence? Are you going to speak about that today?
So I'm not going to speak on what I'll briefly mention. So again, so I'm not a urologist, I'm a colorectal surgeon. I think the reason that was mentioned in our handout is because this is the same system that works for both urinary incontinence, like urine incontinence, and fecal incontinence, because it's a similar group of nerves that manage both. Again, going back to the idea of the different muscles that are involved in the pelvic floor. But if you'd like, an expert opinion on that side, then I think you should get seen by a urologist who would be able to give you their expert opinions. But I can tell you that it's the same system that they use for urinary incontinence as well. Yes? So I've done a couple dozen procedures. I did my training, so I'll tell you a little bit more about myself as well. I did my general surgical training at St. Joseph Mercy in Ann Arbor. And that's a group that also actually uses this system, Medtronic system, to treat fecal incontinence. And then I did some additional training in Seattle where I used this system as well. So that's how many I've done. All right. Any other questions at this time? Yeah, don't be shy.
Does having C. diff in the past, would you take that into account for fecal incontinence? Because it sort of changes your whole system.
It does. So C. diff is an example of infection in your colon. And so it kind of goes back to making sure that we've gone through the steps of conservative treatment for the fecal incontinence. Because if you have a history of that, I would say I would manage your diarrhea first with medications, whether that's secondary to, because I want to make sure that you don't have a recurrence of your C. diff infection. Because I wouldn't be doing you any service if you're still having runny bowel movements. So I would treat the diarrhea first, and then if you're still having issues controlling your bowel movements after the diarrhea has resolved, then I would recommend maybe proceeding with this procedure. Because most patients that have, quote, fecal incontinence will see improvement in their symptoms just by resolving their diarrhea and just by having their diarrhea treated. Because loose, watery stools are difficult for anyone to control, whether you're young or old. So that's the first place that we start, finding the root cause of the diarrhea and then thinking about what we can do about it. Mm-hmm. All right. Yes. I would say at least 4 hours or so. And that's how long it takes for about your stomach to empty. So I would say 4 hours is a good rule of thumb. your blood thinner may not work as well. It may not get absorbed as well. Anything else? All right. Thank you guys for coming. If you have any questions, you can call my clinic.